All right, let's start with this. It's a very objective analysis. I am trying to limit the amount of text. This is an ultrasound lecture that I have made. Images are going to be doing the talking. I'm going to be doing some of the talking. There's hardly any text in here. And this is purely for on-call help and a good thing to refer to as a guide. I'll give you all the printout of this and you can put it up in your call room. So when in doubt about measurements, weeks, this, that, and the other, refer to this. It'll be helpful.
Can you email it, ma'am?
Yes, I will.
Can you email it to us?
Yes, I will. All right, so very, very easy. We're just going to be looking at it. We're only going to know what we need to know. We don't need to know a whole lot of other things that occur and we don't want to know. But I need a pointer. Now this pointer, I don't know if it works or no. Apparently it does. Is that you? Anybody else? All right. So as you know that the weeks of the gestational age are calculated from the last menstrual period of the patient. Therefore, when the ultrasound text gives you an image of a pelvic ultrasound without an LMP, shoot it right back to them and say, I want the LMP. Because you need it for dating for the future 40 weeks of the pregnancy. That is why week 0 is when the patient had the last menstrual period. Week 2 is day 14 to day 16 when conception actually occurs. The first sonographic visualization via transvaginal ultrasound will happen between 4.5 to 5 weeks of the pregnancy. When I say these numbers, these are the upper limits of normal. That is, by 5 weeks, you must see a gestational sac by transvaginal ultrasound. Does that make sense? Okay? By 5.5 weeks, you must see a yolk sac in a normal gestational sac. By 6 weeks, you must see an embryo, not only an embryo, but a cardiac flicker, a flicker of the cardiac pulsation. You may not right now be able to measure the cardiac activity. Am I going okay? Am I going fast or slow? Pay attention because I'm going to be asking you a lot of questions. So by 6 weeks, the embryo appears, the flicker appears in the heart rate, and the heart rate may be measurable, may not be measurable. And by this time, the lower limit of heart rate at 6 weeks is 100 beats per minute. Does that make sense? So she's giving you 110, 120. Don't jump off. It's okay. It's only the very early embryo. Give it another week to pick up some heart rate. Okay? When do you start getting worried? When do you start calling it relative fetal bradycardia? When the heart rate is less than 100 at any point. When do you call it absolute fetal bradycardia? When the heart rate is less than 85 anytime. Does that make sense? So I only want to give you very objective numbers, very objective measurements, very objective weeks for you to remember. So don't try to note down anything. I will pass this on to you. By 6.5 to 7 weeks, you must see the amniotic membrane appear. So Ibrahim, to answer the question, the yolk sac will always appear before the amniotic membrane. Make sense? So the amniotic membrane appears. The cardiac pulsation should now be measurable with an M mode. And at that time, the lower limit becomes 120 beats per minute. Does that make sense? 7 to 8 weeks, the fetal spine develops. By 8 weeks, you will have a head curvature separates itself from the body. So you will have a segmentation of the embryo. You will see a head that looks like a little different. There will be some neck segmentation, a little constriction. So like a head and then a body. By 8 weeks, you should be able to identify all 4 limb buds. Okay? Usually the pregnancies that we see are within 8 weeks. We seldom see any pregnancies that come through the emergency room after 8 weeks. But that's okay. You should be able to see the limb buds. 8.5 weeks, you might see the embryo jump. Maybe it's, it's having to get some movement. And by 8 to 10 weeks, remember this is 8 weeks head curvature, body limb. 8 weeks early intrinsic motion. 8 weeks a rhombencephalon develops. What's a rhombencephalon, Yemezi? Good, the posterior brain, unsegmented brain or cerebellum. Okay, so we'll let the images do the talking. This is the endometrial echo right here. This echogenic line is the endometrial cavity. One very important feature that differentiates a true gestational sac from a pseudo-gestational sac is that the real gestational sac never occurs in the center of the endometrium. It always occurs eccentrically. Have you all heard of that before? We have, right? So the first thing that I look at this and say, this is probably a true gestational sac because it does not occur within the endometrial cavity. It occurs eccentrically within the endometrial echo, right? Because it is not a content of the endometrial canal. It is something that is with the sperm and the ovum met in the endometrial canal, but the embryo implanted itself or buried into the endometrium to house there. Do you understand that? A pseudogestational sac is blood or secretions or pus or what have you that is in the endometrial cavity. It is the content of the canal. Have I made myself clear? Please ask questions. If you don't ask questions, I assume you have understood everything. All right. Here you see a lucency, a small cystic lucency surrounded by a very thin rind of echogenic tissue. Just one rind of echogenic tissue, a single donut, like like a donut sign. This is the IDS or the intradecidual sign. The intradecidual sign is defined as a cystic lucency with one rind of circular tissue located within a thickened endometrium. The thickened endometrium is the decidua, which is the other name for the endometrium of pregnancy. Any questions? None. So this is central or eccentric, Louise? Eccentric. Okay. Intradecidual sign, positive or negative? Positive. Positive. So more towards gestational sac or towards pseudogestational sac? Good. So are you going to go crazy to the tech and say, no, hunt for an ectopic pregnancy, hunt for an ectopic pregnancy? No, you're not going to go crazy. Even if you don't see an ovary, you're good. Now we come to the double decidual sign. The easy way to remember is double donut sign. So DDS, double donut sign. What does a double donut sign say? Double donut sign says that there is a cystic lucency with one echogenic rind of tissue and a second echogenic rind of tissue. Anybody in this room who does not see double donuts? Okay, so this is the DDS, the double decidual sign, and this is a very confirmatory sign of intrauterine pregnancy. If you see this sign, don't get mad at the technologists if they don't show you one ovary. They say we couldn't see it. Right now, our signs are very confirmatory towards an intrauterine gestational sac. Fair enough? So far, everybody is with me? The yolk sac is the earliest intragestational sac structure to be visualized at ultrasound that can absolutely confirm an intrauterine pregnancy, right? The intradecidual sign, the double decidual sign, though are very, very positive. I mean, they may be 85, 90, 95% positive predictive value, but 100% is only when you see a second cyst within the gestational sac, the yolk sac, correct? All right. So here the mean sac diameter is 12 millimeters. Can anybody tell me how to measure the mean sac diameter? Tom? Good. You measure 3 dimensions. So you do a split screen measurement. On the same screen, there should be a split screen, right? 2 ultrasound images can be acquired on the same screen. And on the transverse image, you're taking 2 measurements. On the sagittal, 1 image. And then the computer calculates the mean sac diameter, and then based on 2 or 3 algorithms that are already fed into the computer, it will give you an estimated gestational age. Okay. All right. So 2 or 3 things that I want to point out in this particular, we will not be able to finish this right now, but we should at least start it. Yes?
At which points are we actually measuring? Are we measuring the hypoechoic or the outside volume?
We are measuring within the hypoechoic, just the hypoechoic. We are not measuring the decidual reaction. Okay? The gestational sac is this, the yolk sac is this. Just by eyeballing, you can tell that the yolk sac occupies no more than 10 to 15% of the gestational sac. Right, Ibrahim?
Yep.
Right, everyone? So just by eyeballing and seeing several of these, you will be able to tell, well, the yolk sac is abnormally large. When it starts to occupy 50% or, 80% of the gestational sac, then that's a problem. So the yolk sac measurement should not exceed 7 millimeters. Does that make sense? We don't typically measure it all the time because usually by eyeballing it looks okay. All right. This is probably the first visualization of the embryo, and this is called the diamond on a ring sign. So this is the yolk sac. On the yolk sac, looks like a rock, is like a diamond on the ring, is the very early embryonic pole, right? Please know that the first time that the embryo makes itself visible, in majority of patients, you will be able to see a flicker. Does that make sense? But there are some late bloomers, like some people just start late. So we have a week or two to give them to catch up before we render them abnormal. But for all practical purposes, the first time when you see an embryo, majority of cases, you will be able to see a flicker. This is a very, very early embryo. Crown rump length is 0.29 centimeters, corresponding to 6 weeks and 0 days. What is very important is, and what I tell my techs is, that up to 8 weeks, you just can't do crown rump length and that'll be okay. You have to do mean sac diameter plus crown rump length. Because if there is disparity of more than a week, crown rump length says 5 weeks, gestational mean sac diameter says 6.5 weeks. That's a big disparity in gestational age measurement. That's abnormal. Also, I want you all to know that we are not getting any normal walk-in patients when we do this, because we are only looking at ER patients for first trimester. We don't have an outpatient clinic where somebody has a positive UPT and they come in. These are all vaginal bleeding, cramping, a previous tubectomy, salpingectomy patients. These are patients with symptoms who are coming in. MVC, yes, whatever. So these are not walk-in patients. So the chances of you finding a normal pregnancy are not 100%, probably 50%, because these are patients who are coming to the ER. They are not walk-in patients. All right, looking at this 8 week, 2 days. So 3 things were to happen at 8 weeks, if you remember. Segmentation of the head with the rest of the body, number 1. Appearance of this lucency in the head. What is this, Yemisi? Rhombencephalon. That is why I know this is the head end and this is the tail end, because rhombencephalon occurred in the head end. What are these, Tom? The limb buds. Very good. And what is this structure here, Jared?
That's the yolk sac. Gestational sac.
This is the gestational sac. Abhishek? Very good. This is the amnion. So what is an amnion? So just imagine that this is a large housing community. The embryo has its own private apartment. Okay? So this is the private apartment of the embryo, which is the amnion, in this large housing community, the gestational sac. Does that make sense? So I have seen once or twice people not recognizing a normal structure like amnion and calling it linear echoes and this, that, and the other. No. It is an amnion. It is a private apartment housing for the embryo. Does that make sense? Based on the number of amnions and so on, which we will not discuss today, we will determine whether this is monozygotic, dizygotic, what nature of twinning is happening. But we will not discuss that today. So 4 things happening: segmentation of head with body, rhombencephalon, limb buds, and amnion, all occurring at 8 weeks. Everybody's with me? 8 weeks, head curvature separates, limb buds. 8 weeks, intrinsic motion. 8 weeks, rhombencephalon. Everybody's with me? Now I will transition after this slide to abnormal. We'll do as much as we can. This patient is crown rump length of 3 millimeters, 6 weeks and 6 days by gestational age. Heart rate was more than 122 beats per minute. So, at 6.5 weeks, which is what? 6 weeks and 3.5 days, which is 6.5 weeks, our lower limit is 120. This baby is 122, so baby is safe, right? Okay, shall I go on to this or shall I stop with abnormal?
I was going to ask you if you could explain how to measure on the M mode.
Yes.
Where to choose the.
Yes. Okay, very, very important to know is that all machines that calculate the M mode are not the same. Different vendors have different things. Like in our ultrasound department, when you have a pregnant patient in room 1, where Renita usually is located, you have to do only one cycle, that is one systolic peak to the next systolic peak. One cardiac cycle only to be measured. Does that make sense? One cardiac cycle to one cardiac cycle. However, the machine which is in room 6 and all the machines that are in the ACC require measurement of 2 cardiac cycles. So that is vendor specific. Yes.
I think you're referring to the way we see
Yes.
that form. So one cardiac cycle is one peak to one peak.
Yes.
And 2 cardiac cycles is you skip the peak in between.
Yes. Yes. Okay?
Because M mode measures the different position of the yeah.
Correct. So it is giving you a reflection of the right atrium. It is giving you the curvature of the right, basically the changes that occur in the future right atrium. That is what it is telling you, the movement of the valve, like Dr. Simoncini said. What we see is this peak to this peak to this peak. So you will have repetitive patterns of the same peak. You have to measure one cardiac cycle in room 1 machine and 2 cardiac cycles in all the other machines, if that is something that answers your question. It is vendor specific.
Like, if I have to choose it manually, where exactly the...
One cardiac cycle. So here, she has begun right here, at the beginning of this peak, right here, gone to the beginning of this peak, right here. So this is one, this is one, this is one, this is one. Oh, sorry. Okay. So as you can see, this is one, 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 this is one. Okay, it is not hard to tell. Yes, Aaron.
These 2 cardiac cycles, if you measure 1 cardiac cycle, will you get half the number or will it give you an error?
No, it is just machine specific and I really can't answer that question. Why? All the machines I was used to take 2.
So on the ones that measure 2, do we put?
No, we don't do anything. When you measure 2, it will give you the correct measurement.
No, but my question is do you?
Yes, you skip 1.
Are we putting
Yes.
lines on there?
No. You're measuring 1, skipping this one, except putting the second line here.
Okay.
Skipping 1. Dr. Simoncini, do you have an explanation?
No.
Okay. Anybody has any questions so far?
I think we can stop here and do abnormal.
Okay, we can do abnormal later. Where's Hunter? Where are other residents?
VA, the Hunter.
Huh?
Hunter's the VA.
Under the VA. All right, thank you.